All right. Hello, everybody. Good afternoon, and welcome to the webinar, The Next Evolution in Virtual Nursing, Bridging Technology and Practice. We are so excited to bring together two incredible nurse innovators to dive into this important topic. So if you're joining us today, you are in listen-only mode, but we'd love for you to be a part of the conversation. So feel free to drop your questions or commentary into the chat at any time, and we'll have some time for Q&A at the end of the discussion. Also, we will be sending out a recording of the session after the webinar if you want to go back and watch it again. So I am excited to introduce our two speakers today. These are two great nursing innovators that are really shaping the future of healthcare. So first up, I'm excited to introduce Brie Laughlin. She recently joined Avasure as the Executive Director of Virtual Care Innovation. You may have seen the news that Avasure acquired Nurse Disrupted, which is a virtual nursing company founded by Brie, and we are so thrilled to welcome her onto the team. So Brie is a nurse innovator through and through. She's worked with health systems around the world to design technology that truly transforms how care is delivered. From leading roles at Epic to launching her own virtual nursing company, she's been a driving force behind shaping the future of healthcare tech. So Brie, welcome in today.
Thank you.
Next up, we've got Lisbeth Botruba. Lisbeth is going to be leading our discussion today. She is a third generation nurse and again, a true pioneer in virtual care. Lisbeth's really spent her career pushing the boundaries of how we deliver care, but always with a nice focus on improving safety for both our patients and our staff. Her leadership in nursing and passion for innovation are really at the heart of what we're building at Avasure, and we're lucky to have her on our team. So with that, why don't we go ahead and dive into the discussion. Lisbeth, I'm going to pass the mic over to you.
Thank you so much, Nicole. And we almost didn't start on time because we were talking. So we just love talking together, and we have such a passion for this topic. So very excited about the next evolution of virtual care. Where are we now that we're in April of 2025 on virtual nursing? And Brie is a true nursing entrepreneur. And whereas I have called myself in the past an intrapreneur, which means that I have done innovating but within kind of a corporate structure like here at Avasure. But Brie is an actual entrepreneur. So very excited to get started. And what we were going to talk about first is kind of where the market has evolved with virtual nursing. And we have some very solid and trended market research that we want to touch on to kind of give us a place to start from. And so Jocelyn Insight has done market research in the nursing area, is really the top market researcher. They work with DAISY, they work with ANA, the DAISY Foundation, ANA, A1L, and they have also worked with Avasure. And so we did research in 2023 and then early 23, later in 2024, and kind of asked some of the same questions to see how the perception is evolving. I think we had almost 1,000 respondents between those two market research surveys that we did. And you can see in early 2023, when we asked, do you believe virtual nursing will become an integral care model, integral to care delivery models? 66% of leaders said yes, and 33% maybe. And then 18 months later, it was even stronger. 74% said yes, and 24% maybe. And then there was a really awesome market study done, and this has been, I think this is the fifth or sixth in the series with Jocelyn and A1L. And you can find this and dig into it. There's all kinds of wealth of information. And this was 2,600 nursing leaders responded. And kind of the same thing, which advancements is your organization going to continue to for redesign healthcare? And again, virtual care is up there, number one. So we know that this is there's continued commitment to virtual care and virtual nursing, and so that's one of the reasons why we're talking about it. And there's so much more that we could talk about. My eyes are drawn down to the AI questions. down 7 and 8 here on this, about 7th or 8th, the application of AI in patient care delivery is higher than AI in business operation efficiency. So that's surprising, but that could be a whole nother webinar, right, Bree? And I think Bree will be talking about that at ATA.
Yeah.
Yeah, any thoughts on this before we do our polling question, Bree? From your perspective, have you seen the same evolution?
Oh yeah, I have. I mean, I think it's a great way to set the table, Elizabeth. Like where, we're seeing that, virtual care is not a transactional, strategy of the pandemic. It's now, a long strategic plan. And I think that's why a lot of us are here is saying, okay, how can we design the future together, in a meaningful way? So I think a great foundation.
Yeah, and what have we learned from all the experimenting that has been going on for the last few years? And we're going to try to touch on some of that. But first, I'd really like to start an audience poll, and look at this. With this strong commitment and growing commitment, why isn't it even more widely adopted? And so I'd just like to hear the audience perspective. Budget constraints, I'm going to put that on also with financial uncertainty just in our environment right now. Some academic organizations aren't sure where their NIH fundings might be getting cut or is getting cutting. And also maybe what's happening with Medicare, Medicaid. And some may have started and done a good, nice little pilot with like homegrown technology. And so now we want to scale, you've got to invest in more technology. So excellent. So it looks like lack of confidence in the ROI. So we're definitely going to talk about that. And the other issues too, and competing priorities is a perennial issue. Great. Thank you everyone for answering. So just kind of talking about that ROI piece, and we wanted to start with really what's foundational and what's a good starting point for virtual nursing that is solving a significant problem for a health system first. And Bria, just what are you've been working with virtual nursing, I don't know, 5 years now. So what is your perspective on that?
Well, I mean, I think the poll shows, I love it when the data shows what we anecdotally are the conversations are happening and
Yeah.
where we are now. I mean, throughout the pandemic, hospital operating margins were never huge, right? Compared to, Facebook, once upon a time, their operating margins were like 70%, and hospital systems always rode around 5%. And in the pandemic, a lot of them went negative, right?
Yeah.
And so, nursing, of course, being the, largest operational cost of hospital systems, we've got to show the ROI. And so that, that pressure of here is, 2020 to 2025, where's the money? Competing priorities, I think we'll unpack that later. I mean, coming from Epic as well, like I know how much a CNIO, is responsible for every piece of technology that comes across your health system, but also there's a big weightiness to these, core foundational systems. But we'll talk about, I mean, consolidation and lightening up the burden of competing technologies and competing priorities is a really important and key strategy that I think about all the time. And, and how we can weave that in so that the innovative programs, needs to be there, as we saw from the virtual care survey. Like, I'm a nurse exec. I know that virtual care is important. What keeps us from it? ROI and competing priorities. I love setting the stage with that because I think we'll be able to talk about a couple of strategies that our customers and that we've come up with to help break down those barriers and get super focused on realizing your vision and expanding.
Yeah, and I think that the answer to what is the ROI for virtual nursing that will really kind of fund the resource that has to be invested in it, I see it falling into 4 categories and starting to get pretty clear. And the first one is workforce or staffing, and retaining, attracting, or staffing. And then the second one is on the quality side. and like ultimately readmissions or quality issues that are costly to a health system, and how a virtual nurse can help mitigate those, patient experience, and then lastly, throughput capacity constraints. So we will take a little bit more time deeping into that capacity constraints, because that's bubbling up in 2025 as a bigger and bigger concern. But I'd also like to just take a few minutes and talk about those others, the workforce issues, the quality and patient experience. Which of those is your favorite to talk about, Bree? When you're talking about virtual nursing?
Just going for it. I mean, I love to talk about cash money. Are we just going for the ROI?
Cash
I didn't know
money.
if we were gonna. I didn't know if we were gonna go through another AONL nursing leadership insight study slide with capacity on it, or we're gonna go where we want to
I'm
go.
saving capacity for the last one. But so before we get to capacity, I kind of wanted to talk about those other strong ones: the workforce, the quality issues, the patient experience, and how we can kind of connect the dots to financial outcomes.
Okay. Well, for us,
Yeah.
we've talked about with virtual nursing, there's short game, long game, and moonshot. Your short game has to address ROI, and you guys were not guessing anymore on where the return on investment is for virtual nursing. It's in throughput. It's not a mystery anymore. Like, it's so interesting, Elizabeth, you and I were at THMA last week in DC? Oh my gosh. And here we are hungry to innovate, to create the next, but your foundation in virtual care to achieve the ROI. I used to say this when I would sit with organizations that we were preparing to go live with virtual care. As a startup company, you can't miss. You have to thread the needle precisely. And I would say, of the subject matter experts that need to be at the table with the project planning, it is your CFO. I love making best friends with CFOs. And I would say I would play poker with the CFO, which is what are your strategic targets on cost containment? And they live in 3 places. And this is true across, the industry with people who've had large scale virtual care programs. Your CFO will recognize hard revenue in relationship to your virtual care, your virtual nursing program. Now, Elizabeth, this is different than telesitting, and I want you to come back to that because of virtual care, I think that 2 core pillars are telesitting and virtual nursing. Your core virtual nursing lies in throughput because your CFO already has, probably down to the minute, a dollar allocation for how ED boarding, for order to discharge, right? And to overall GMLOS, right? Your geometric length of stay. And these with virtual throughput, your admissions and your discharges, this is something where you can move the needle pretty fast. If you stay focused on that piece for the beginning of your program, the low-hanging fruit, and Elizabeth, I know you have some updated data on, what a common dollar attribution is for ED boarding.
Yeah.
But I mean, when you look at at the ROI calculator that we would have, where it's like, okay, your hourly pay for nurses, a 500-bed hospital, the amount of time it takes to facilitate all of your discharges and admissions, the cost of that, you wind up with something like a 1,000% ROI when you stay focused on, ED boarding, GMLOS, and throughput. And that creates your financial foundation for what we know needs to happen next. Typically it's our new hire support. It's our peer support. There's just not as direct of a dollar correlation to the throughput and capacity management, right?
Yeah.
It's part of your house-wide strategy. So make friends with your CFO if you're not besties with them, grab them a coffee and grab them a coffee.
Absolutely. Or who is your financial buddy? Yeah.
Yeah.
I think let's show that slide that we have on, and this is another one from the AONL Jocelyn Insights survey that was earlier this year, January of 2025. And this was a great question. They asked these 2,600 nursing leaders, what tasks have required your attention in the past week? And then which tasks provided you joy and which tasks provided you frustration? And so really interesting way to line it up too, which is what Hunter Jocelyn is so good at, taking the data and telling a story with it. I'm first going to just take a minute about the joy side, that it's about mentoring, recognition, engagement, retention. That's what gives us joy. I'm like, who here has participated in a Daisy Award? And that will fill your bucket and last for, a week. And then on the but dealing with capacity issues, no, that doesn't fill anybody's bucket. And it was the number one frustration on this survey. And I think when I'm out visiting and speaking with different nurse leaders, and Bree too, capacity and bottlenecks is really a big problem now. And it's certainly not going to get better. And especially cuts to mental health care means that emergency departments are ending up holding the bucket, or holding the bag. And so on this next slide, like you mentioned, Bree, we do have some dollar amount. If your CFO can't pull out, or your financial person that you work with can't just pull out of their back pocket your costs, which would probably be higher, because one of these references is a little bit old, but one patient left without being seen costs at least $1,000. It was a really good study that was done on this, although it was done in 2011. And one ambulance diversion cost $4,600, and that's not a trauma diversion, that's just a regular. And they averaged that out, just the percentage that would get admitted or not admitted. And so I recommend anybody reading this article for themselves. And actually, Bree, you sent it to me. That's why I have it right here. And then it's plain old more expensive to take care of a patient in the emergency department than it is to take care of them on a med-surg floor where they belong. And that's operational costs and staffing costs. That's not overtime. That's not anything about lost revenue. That's not, the increased length of stay. And then obviously that's not satisfying for ED staff if they have a lot of boarding patients they have to deal with. And so just one RN turnover, and that's probably higher for an emergency room nurse. So those are some examples of how you can look at your own data, take these dollar amounts, and start to build a business case, so that you could say something like, if we can just increase our discharges by 11 a.m. by 2 more patients, this will pay for itself because of all the costs that you could offset with that. I'm going to move to do you have anything to add on that before I move to the next slide? Because there are also...
No, I think if anyone's struggling with this, just reach out. I mean, people who know me, it's like, I'm happy to share like ROI calculators, and, again, nurse leaders across organizations, regardless of the solution that you decide on, we've been sharing. It's time to share, all right, to demystify your foundation. So please reach out. We're happy to help you with your journey, however it is you're struggling with this, like talking about cash money. I love to help with that.
Yes, we do. We certainly agreed. And then on this next slide, the non-financial impact. So I got to start and explain that picture that I put up here, because I think it's probably distracting. Like, what is that? So my daughter was boarded in an emergency department. So she is a college student, and she has severe dairy allergy, and she was having an anaphylactic reaction, and she went into an emergency department, and she was sat in a chair in the hallway. And the nurse started an IV, which was kind of messy, but there was no towel nearby, or really even sink nearby. So she just kind of took the sheet and sort of wiped the blood around. And my daughter started talking to the lady next to her, who had been there for 48 hours in a chair in the hallway in the emergency department. And if any of you are moms of college age students, getting a Snapchat that says, bruh. It's like, she was fine, but it's just the patient experience obviously is really impacted by it. And just kind of moving to that middle column there is evidence that shows that boarding leads to increased verbal abuse and burnout. and the quality is on just 12 hours of boarding equals increased 2% in mortality, increased 3.1 days of length of stay. So I think this is why we're kind of Bree made the, I think, bold comment that the strongest virtual nursing business case is probably on throughput. It's faster to measure. We're just seeing that being so widespread. So I think, but before we move on from that too, I want to say that there are also impacts on retention of nurses anywhere. Getting a nurse to stay maybe a little later in her career because she or he could do virtual nursing, as well as readmissions. If you get a really solid discharge done by a virtual nurse that's not interrupted 17 times, it's going to impact readmissions. It just takes longer to measure that, and patient experience as well. So I think we're ready. We don't need the slides anymore, but we did get a question when the registrants, one of the registrants asked, and Kim comes from a children's hospital, and her question was, what is the ROI for virtual nursing? And I know you have some specific experience with that, Bree. So do you want to share your experience? And I'll share another case study that speaks to the question that's put in.
Yeah, absolutely. I loved having the opportunity to go live with a pediatric on the East Coast. And the question was, is this going to be different for a children's hospital? And when we sat with the CFO, the answer was no. They had the same throughput targets at the pediatric hospital. And so they started off, with throughput, even though they were big picture and all of these ideas. Really, when we sat down on hard ROI, that was it. However, some other really cool things happened. So I do love to tell this story. There was a patient, and I know we have people from pediatric hospitals on the line. You wind up with kiddos who grow up in the hospital. And this particular story comes from a patient who was 18 years old, but had been a frequent flyer their entire life at this particular hospital. And the parents were really involved. In fact, they were on the patient advocacy board. I mean, they were very influential in the health system. And they were able to receive a discharge in one of their admissions from a virtual nurse from the hospital. And this parent could not talk about the experience enough. It was the ability, and I do love, the surveys. I know that we've won when the bedside nurses say, my day is better, the quality for my patients is good, that I feel like the work is lifted. Listening to your bedside nurses and having them be your North Star is so important. The virtual nurses satisfaction is often high because you get to practice in the way that we were trained, that we are using the best of our skills. And in this case, that virtual nurse doing a discharge was doing this very complete, methodical education, discharge and coordination, and ensuring that this family had everything that they needed. And that family believed that, they had so many readmissions that the thoroughness, the thoughtfulness, and the time that was spent by that virtual nurse was the best discharge that they had had in this patient's entire life. Wow. And they advocated for it moving on. This was something that they continued to talk about, that experience with the virtual nurse. And Elizabeth, we are seeing the data coming back that readmission rates do go down, and HCAHPS scores. There's suggestions that especially that discharge education and the discharge medication education, that score winds up going back. And agreed, that undivided attention to be able to do thorough education and make sure the family has all of the tools that they need is we can. I was going to say appease, but I'm going to say we can hit the goals, the financial goals through throughput, but we also are seeing these quality and outcomes goals that are a little bit of a longer measure in a softer ROI in the end. But great data, great stories coming through, and the patient experience and the nursing experience, where I get satisfaction of practicing in the way that is to the best of my capabilities, and I can see these amazing outcomes of the patients. So, I mean, I haven't told you this. This is kind of I don't know if everyone remembers when I started Nurse Disrupted, you guys, I was a virtual nurse too. I played every role in here. I'm a registered nurse and I was a virtual nurse, and being able to make that eye contact and have that true experience with the patient. I can say personally, it's very rewarding, and it's coming out in the surveys as well from the experience of our nurses.
I was looking at a registration list, and I know there's at least one person registered who listed their role as virtual nurse. So
yeah,
feel free to write, whoever you are, if you're on, feel free to write something in the chat if you have something to add about your satisfaction and engagement in your role. So really appreciate that we have at least one virtual nurse on this call. And so pediatric implementations for telesitting or virtual sitting are different than adult virtual sitting. So we see quite a difference in the reasons, not in the ROI, which is on decreasing 1-to-1 sitters. So if you're monitoring 1 to 12 or 1 to 16 versus 1 to 1, that is an exponential ROI that has been repeated over and over again for many, many years now. But on the pediatric side, it is very sobering, but the majority of the virtual sitting that's done across our multiple pediatric hospital implementations is for low to moderate suicide risk. And it's just scary how the age is getting even younger with that. And that can be in the emergency department or on the med-surg floors. And also, there's a great ROI for eating disorder patients because it's just really a pain to have 1-to-1 sitters during mealtime and just like to juggle that, and mealtime, it happens all at the same time. And so there's some good evidence, and please reach out if that's a use case that you're interested in, because I had a DNP student with me for a semester, and she did a great project on that in collaboration with Mass General. So we have a good presentation and good clinical evidence on eating disorders in the pediatric setting. And then we have one Midwest Children's Hospital that started with virtual sitting and had a phenomenal ROI that's kind of funding a device in every room. And their first virtual nursing use case is on their educators. So their educators can be quickly available virtually for their more novice nurses. And it's just so much easier for them to be able to call in a virtual nurse educator when needed, maybe a new equipment or some new skill set that they just want that, at the elbow mentoring. So, and they already have that infrastructure in place from the kind of core ROI that they started with virtual sitting. So, and I loved how you said near term, long-term moonshot or something like that. So I love that.
It's a short game, a long game, and then a moonshot has nothing to do with golf, right? It has to. So yeah, absolutely. I mean, I love being a futurist and I love being an innovator, but our short game is solving real world problems. We talk about this a lot. And Avishar has a lot of us are nurses and nurse executives here at the company, and talking about, that the short game of your expansion needs to be focused. But then you have your long game where there's a virtual care strategy, and then that hunger for your own unique contribution to the virtual care, to the body of work for virtual care. You play your short game, you lay the strategy for your long game, and then you get to push the boundaries of innovation with a moonshot, when you have all of these pieces in place, because we want to transform care for the better, right? We really want to, we do want to create, a better tomorrow with the work that we're doing today. So
what are those kind of innovative ideas that virtual care can be leveraged for that get you excited, that are a little more edge?
Edge.
No, I don't mean like.
Well, there's that which gets me excited. Yeah, but let's talk about the landscape of virtual care, and notice everyone, we're using the terms virtual care, right? And I think this is an important distinction. 2020 to 2023, we were in a pandemic. We went from bad to worse in regards to workforce resources and what was happening with nurses. The term virtual nursing became a thing. You know, it was part of the ANA work group to define virtual nursing. But now emerging in 2025, it's virtual care. It's end-to-end interdisciplinary virtual care for a lot of reasons. I mean, there's a shortage of everyone. There's not enough of us, and there's going to be the silver tsunami coming down. There's going to be more patients, and there are a lot of things that we have to figure out. Virtual care has a lot of technology components to it, and I think that there's you know, you and I were talking about it. I mean, there's all the rage in Paris on virtual care, right? There's the meat and potatoes. But when I think of what I hear again and again is, you know, people cannot get away from ambient voice documentation.
Yeah.
And I like to call it chat to chart, and I swear if someone trademarks that before I do, good on you. But anyways, nobody can, there are, like, you know, huge companies that have been working on this for years, right? It was the Microsoft acquisition of Dragon Nuance. It was, you know, Amazon ATM. They've been working super hard at this. I mean, my world at Epic back in 2012, we were demoing on the UGM stage the, you know, Nuance, you know, smart room where you can go in there, you can just have a conversation and it can document in the chart. So this isn't a new thing. It's just the new hot shiny thing that everyone wants. And, you know, the startup companies, the mid-range, you know, companies like Abridge and, you know, everyone is hot to trot on this chat to chart piece. What gets me excited, if you know anything about my past research, it has a lot to do with, it used to be using predictive models, right? And precision staffing is something I made in Epic, but now with generative AI, consuming the data of, and we're uniquely positioned to do this in virtual nursing because you can tell better than, you know, in like a workflow navigator, to use Epic terms, when you're a virtual nurse, you know that you're performing a particular workflow, even if it goes between disparate workspaces in your EHR and other technologies that you're using. And so the data and analytics to look and say, hey, if you are deploying new grad support, for instance, you will need 20 hours of virtual nursing time in order to support the demand that you have for the new grads. And that might be different on, like, for Southeast transplant that I worked on at UW Health. There are a ton of new grads there. We needed a lot of support versus, you know, neurology, where we had people who had been there for 20 years. There, you know, each hospital unit, as we all know, is not the same. But to use generative AI to say, hey, based on the amount of time that was used last month, we can predict the type of nursing resources you need in the hours. This is where things are going. This isn't something that we're doing here today, but it's the foundation that I get excited about when I'm like, the problem that I have is, do I have my staff in the right places to get the job done for the patients that need it and the staff that need it? And so solving that problem with generative AI is what gets me so excited. Touchless physical assessments, yes, all day long, that I don't need a device integration for a cuff that I'm wrapping around somebody's IVs inconveniently. You know, that there are companies that we've been working with and that are in the industry that through computer vision, and I'm so excited about all of the use cases of computer vision and AI, but you can get respiration, you can get heart rate and rhythm through computer vision without a single device being connected to a patient's body. That gets me excited because we start getting some of this meaningful data with some of the alerts that can actually help me with patient care. And I don't have to, you know, put that cuff on and hit the button, even though it's flowing, you know, into my EHR.
I can imagine a world where, you know, all these things, both of those. And it's funny because I have my little passion project too, that would be, or that I've researched, is workplace violence. And so what I'm really excited is when we can get to the point, and this is probably a little closer than some of those, is being able to use ambient audio and other indicators that a patient is escalating in the room. And that may be based on some trigger words, which I have done research along with Joe Kaminsky and Pat Quigley on what those words are and those threats are, as well as tone of voice and other sounds. As we know, patients who are escalating will take out their aggression on inanimate objects sometimes. So if they're like banging the side table, that's an indicator. And I'm so excited for AI to use the microphone, which is in the patient room, ambiently to let us know ahead of time. So you said it, you said, what's all the rage in Paris? And it's kind of like, what are these kind of exciting features? And I would love to hear anybody to throw in the chat, like what would be your thing that you're super excited about, that where you've seen we can get there with virtual care, and we need to get there sooner than later. So would love to hear from the audience what you're excited about, thinking vision, thinking futuristically. Is there anything else, Bree, that, I think I love the vital signs and just kind of monitoring the room. Like it's in a weird way getting back to old fashioned nursing, where you can just do the hands-on that I imagine my mother and grandmother did, but the documentation is happening automatically.
Yeah.
I mean,
I just want to make a plug for Gene Roddenberry. If there's any other sci-fi geeks out there, like I love Star Trek, and when the new and the old and everything in between. But like, come on, you go into the medical bay and you walk in, and just everything is, the vital signs are taken, and Bones is talking out loud, and he nailed it. Here we have the ambient. It's like the Tiger House for rooms, and it's where we're going, and I love it.
So I think it's important then to if you're like, what is our virtual care strategy for our health system? And of course, we always have to start with the problem. So we did start talking about what are some of the core problems that a health system needs to solve, which would justify the investment. And then, but also once you're there, what's your long-term vision, and how can you make sure that you're set up and you're future-proofed as you're solving that significant problem, which may be less sexy, but you are set up for the longer term vision. How do you pick the right technology for that? And I think this is the right order of thinking. Like, you start with the problem, and then you think what's your long-term strategy, and then you go with the technology, rather than starting with the technology and trying to figure out where would this shiny object fit in our health system. But now that we've kind of talked through some of those, what are some of the, how do you make sure that the technology is future proofed?
Well, I mean, don't you think it's not just that it's future proofed, but something that the pandemic brought us is an unsustainable tech stack. So I think things were very tactical in virtual care from 2020 to 2023, and it was like, how can we get a solution? How can we get a solution? And people wound up with lots of different vendors, lots of different contracts. The long game strategy is an integrated enterprise virtual care solution. The EHR will be at the center. This is not something that you can just decide to go, and rip and replace quickly. That clinicians need to live in that. But we think a lot about the acceleration of the advancement of technology. I mean, ChatGPT just had its breakthrough, you guys, less than 3 years ago. I think it's like 2.5 years ago, the big breakthrough happened, and look at where we are now. So there's a push and pull of the next year or two will bring, if I have my, crystal ball or whatever, the next couple of years are going to bring a consolidation of technology stacks. However, there has to be, and we talk about this a lot, Elizabeth, where we have to be able to be the integrated solution, the integrator for virtual care. Because when we work with our customers, it's like, okay, you have telesitting and you have virtual care for throughput in some care areas, but you have a legacy contract with Teladoc for telestroke in your emergency department.
Sure.
And you have a huge MyChart bedside, right? And you have a huge MyChart bedside initiative. And then, by the way, you invested in a startup company that has this awesome AI algorithm, that really does a great job of, touchless vital signs. And so, having partners that are flexible and saying, listen, I'm not going to try and be everything to you. However, we are going to be a consolidator of your solutions. So for instance, when I think of, our inpatient nurses at the bedside, you're going to live in your patient list. A virtual nurse might live in nurse or in unit manager. But how is it that you can use that discharge list to take those video calls from, wherever they're coming from? And that as a clinician, it feels very, very seamless. So Elizabeth, I don't know if that answered where you were going. I mean, we talk about a lot where it's like, if there's another ChatGPT boom and breakthrough, we've got to be flexible with, partner APIs to say, this isn't a closed system. And truly, although we have to consolidate your tech stack and upcycle and be strategic in that integration, we also need to, like you said, future proof. And I think the best way that you can do that is be integrated.
Yeah, I have to tell you something though. About a year ago, I was talking with a group of nurse leaders and explaining that Avasure we had changed our philosophy on that maybe 2 or 3 years ago. Like, we cannot be proprietary. We have to have open APIs, or not open, but standard partner APIs. And I noticed them like whispering and like looking. And finally, one of them is like, "What's an API?" Because I think that's a staffing company. and so, can you explain what an API is? Because
yeah, I love it, right?
I didn't know that.
I know. And tech nerdery is my world. Like software, I mean, aside from practice, so it's an API stands for application programming interface. So something that, and what it's an interoperable. It's saying, listen, here's our architectural plans for you, and we'll actually help you, make sure that your architecture can work with our architecture. The advantage to being the eyes and the ears in the room. So with that computer vision and what Avasure has done is become the eyes and ears of the room. And there are a lot of technologies that need that access. And so that open API allows us to say, okay, you've chosen, for instance, Abridge as your vendor of choice for chat to chart. Great. We are not open to the universe. Like your cousin Jim can't, go in there and decide to like go in there. It's a partner API. But it is a commitment to partnership and saying, great, here's our architectural plan so that we can be interoperable with the partners that you've selected in regards to a vendor ecosystem.
Yeah.
Yeah.
I think, and this is what we really heard. Bree and I were together at a CNIO summit in DC just a couple weeks ago. And they really talked about the need for sort of a platform with a capital P. And instead of just small solutions, like you said, solving just a minor problem, you don't have the IT resources to support that. So you really have to choose a partner that is more of an enterprise and then for virtual care, or it could be your EHR is kind of like the platform with the biggest capital P, but also it might be, radiology or physiologic monitoring. But then with the ability to partner with those that are really the best and the brightest on those different features and integrate and interoperate with them.
Right.
So that's the vision. Yeah.
Right.
I think we had a few questions pop up. So Nicole, do you want to share with us what questions we've gotten?
Sure can. Just give me a second while I'm hopping back on. So if we're going to transition to Q&A, I'm just going to give a final call for questions. I see a few more popping in here. So while we're letting those populate, just wanted to do a quick plug for our upcoming symposium. So this is Avasure's annual customer event that's going to be taking place September 15th through 17th in Charlotte. We're really excited about this one. It's going to be a really great event with hands-on learning, hearing the latest research. You're going to see Lizbeth and Bree there. We're going to be talking about the proven best practices in virtual care, and we're going to have some fun while we're doing it. So go ahead and use the QR code listed here to register, or you can go to avasure.com to register. The registration is free for Avasure customers if you sign up by June 1st. So head on over to sign up, and we hope to see you there.
Those who are on the call might be particularly interested in virtual nursing, and we are giving away 3 scholarships to the Virtual Nurse Academy, which is a very well-known virtual nursing academy. So that's valuable. So if you sign up before June 1st, you are eligible to win a scholarship to Virtual Nursing Academy too. Just thought this particular audience, Nicole, might be very interested in that.
Very exciting. All right, so we do have a few questions in here, so I'm going to try to combine some thoughts here. Bree, I'm going to start with you here. So given your background at Epic, there are questions on how open or flexible is the large EHR's approach, such as Epic, in partnering with vendors that provide virtual care? Or in other words, how are systems using Epic or their EHR to support virtual care?
Well, I mean, the EHR will be our hub. Like if we want a seamless experience, like I said, it's you have to. It's your certified EHR. Your billing is run off of it. We have to live within it. It's interesting the way you position that question, Nicole. I mean, something that is important to me, and something that we know is, in order to be that integrator and consolidator, it's up to us. It's up to us understanding where the workflows are and making sure that we're designing to it. So, something that I know is, MyChart Bedside is a big Epic initiative. I know as a practicing nurse and inpatient, the bedside nurse, which is where the pressure is at the bedside, that I'm going to live in one of 2 places. It's going to be patient list or it's going to be unit manager, right? The Epic-based integrations for some of their products will come in there. We'll talk about Epic Monitor another day. But it's something in understanding deeply, how I practice as a nurse and what the EHR configuration is, and then designing to that, because it's not going to come the other way. It's not going to come. It can't come the other way. It has to be, where we're positioned in knowing what the ecosystem is and knowing how to play in that ecosystem with the integrations, so, Avasure done the hard work of, making sure that we can create that seamless experience in the workspace that we know you're going to live in. I mean, in that early poll too, with competing priorities, CNIOs, I know a huge part of your life is in the EHR and sustaining that. And I think another thing, from now being on the other side or whatever you want to call, what I am now, your job as a vendor has to be to lift that weight from you. Another project does not help you. And so just understanding that, something that I've always said, if you talked to me before, is do not reinvent the wheel. We don't need to do what your big EHR vendors do. We need to be symbiotic in filling the gaps that are not covered by your EHR. And that needs to be our North Star, is to serve our customers and our patients in filling the very real gaps that are there in getting across the finish line in, having a robust enterprise virtual care solution with the flexibility to pull in, the third-party vendors of your choice, not of someone else's choosing. I don't know if I said that diplomatically.
No.
Yeah. Did I answer the question? Did I get to what you wanted me to get to? Or do you think the question?
Mm-hmm.
No, I think that's good.
Yeah. Yes, you did. Thank you.
Yeah. Good.
All right. Next question here. What educational strategies do you recommend that we adopt to teach future nurses about virtual nursing?
This is from my friend Catherine, who I hope is on from Ania. I know. I saw that. I'm so glad you're here. I'm not to interrupt, Elizabeth. I'm going to do a quick thing. Nurse Disrupted was born with nursing students in homeless shelters. We went into the inpatient in 2022, something that really aligned with Avasure. And there are a lot of things that align with the merger that happened with Nurse Disrupted. One, Avasure's commitment to nurse-led. And thank you, Lizbeth, for your leadership on that and nurse-driven solutions. But another piece is with your long game strategic vision. When I say virtual care is a multidisciplinary system, that group functionality for virtual care is amazing for nursing students being able to observe preceptors. And they can observe the virtual care preceptors at the bedside, but they can observe the virtual nurse that's practicing. We've worked with a lot of academics, you guys, and Oleg, I don't know if you're on here from University of Washington. The Digital Health Innovation Hub is next level. We've done some incredible work in Washington State with the University of Washington. We've done work with Jacksonville University in Florida, and I'm finding that academics they recognize that virtual nursing is the way that nurses are going to practice. I mean, they may be the bedside nurse for the first 2 to 5 years of their career, but they're going to have to understand a hybrid care delivery model in this way, and they're putting them in their sim labs and they're incorporating them in their digital health innovation strategies. And then it's our job to be able to say, hey, this is the technology that we've extended. And by the way, I love collaborating with schools of nurses and nursing and sim labs all day long. Like, there is some incredible innovation and cutting edge thought leadership happening in collaboration with our academics. So Elizabeth, that was longer than I wanted to say. I know you probably have a couple words with the academic partnerships Aubishure's had through the years.
Yeah, I just was messaging on the side to get that, and we'll put it in the chat, a link to the webinar that we just did about this earlier this year with Chamberlain University and the system CNO for community health services about just getting more upstream on the education. So yeah, I thought you had a great answer too, but that should be in the chat. It is. Yeah, great. So it's a great question. Yeah. Do you have any other questions?
We do. Yes, next question here is, how are hospitals handling consent for AI ambient listening virtual sitting with audio?
I think you need to mute, Nicole. I'm hearing an echoing, but maybe
I hope it's not me.
Oh, can you mute too? Because I'm still.
I can mute.
Okay, and then we'll just unmute when we talk for the rest of the next 5 minutes, and that should work. That worked. So consent for AI and virtual sitting is a really good question and an ethical consideration. For virtual sitting, it's very cut and dried. The CMS conditions of participation has very clear guidelines for that, and consent is not needed for virtual sitting if you meet 4 criteria, and one of them, it's not recorded, and the second one is that the screen is not visible to the public. The third is that it is for a clinical need. It's not just for educational purposes and doesn't help the patient at all. And then the fourth one is the patient is aware. So it can't be like an AnyCam hidden camera. They need to say like, oh, you're being monitored. So virtual sitting is very easy. On the AI side, we do have intellectual property on how we are able to comply with HIPAA. And Nicole, do you know how we describe that patent that kind of protects the patient's identity?
The idea behind it is to take the kind of outline of the patient, but replace it with different images. That way the identity of the patient is protected. So even when our cameras are picking up video feed, it is instantly anonymized. For that way we protect privacy there. All right, with just a few minutes left, wanted to kind of circle back on the theme of the webinar here, really, is bridging technology and practice. And there's often concern, especially with what we're hearing out in the marketplace at these big shows, that AI and technology is potentially going to replace clinicians. So in reality, many virtual care models are really designed to support and extend the care team. So how do you approach designing solutions that are truly helping clinicians at the bedside rather than adding more burden, adding more alarms, or replacing them?
I'll take a first stab at it, and interested to hear your thoughts as well, Bree. But I think the the question comes from what we learned from implementing electronic health records so many years ago, that it ended up being, in some ways more of a burden than a help. And so the design must be, and the workflows must be designed in a way that support nurses and any bedside clinicians. And what I'm very excited about is how much nurses are taking the lead this time around. And Ania is one, I'll give a shout out. And I'm on the A1L Leadership, Innovation, Technology, and Transformation Committee. I know ANA also has a virtual nursing expert panel. And all of those, I'm just thrilled at our discipline, the discipline of nursing, and how much we are taking the lead on virtual nursing to make sure that it is an enhancement and not a replacement of care. But what are your thoughts on that, Bree? You're on mute, sorry. Because of the echo thing, we muted, yeah.
I was saying a couple of principles that I live by is one, humans need to be the antagonist of any technology story. Any technology we design, it is the humans first. It's a very different design perspective than a software developer who starts a company because the antagonist is the tech and isn't the tech cool, and why aren't you adopting it? When you are saying it is the nurses and it's the patients that are the center of the story and you're designing the technology around it, then you get to the endpoint, Elizabeth, that you're talking about, which is what problems am I solving? Am I lifting workload? Am I increasing safety and experience and quality? If you achieve those things, nurses would wear a spacesuit to think that they saved an extra patient in their career. There is no boundary of what we will not do to improve the lives of our patients and our colleagues. The second design principle that I always live by is that good technology should be like oxygen. It should be invisible and vital. It is not the center. It is not the thing that we do. It should be an elevated overall care delivery and care experience because technology gave us the opportunity to elevate the human condition. So design principles I live by.
Yeah. Thank you both. And that's really important because that's definitely something that we're hearing, especially amongst end users for these technologies, is to make sure that they know that they're being built with them in mind, that they're being able to extend and support them. All right, with just a minute or so left, I'm going to ask you guys a final question. So what is one piece of advice that you would offer to any organization who's looking to embark on their virtual care journey? Elizabeth, I'll start with you.
Yeah, mine is start with the end in mind. So start with the problem that you really need to solve. That's a significant problem. Get the strategy, and then add the technology that fits that last.
Yes, I absolutely in on that problem based and also what technology serves you, what actually solves the problem, the workflow. Adding to that, something that we alluded to earlier as well is, virtual care in 2025 and the next 10 years is an integrated, interdisciplinary, cross continuum of care solution. So short game, long game, moonshot, going back to that short game, your problems in the beginning, we're not going to guess anymore. There's a couple of outliers, people who have talked to me from cancer organizations, some critical access hospitals and rural hospitals. They've had some incredible use cases where it's like, yeah, you're right. Actually, you're going to start with non-stress fetal monitoring. Never thought about that because 20 rural hospitals closed around you. But for 85%, to Elizabeth's points, get your fundamentals down first and scale it. But know that as you're looking at the solution, that you got a really good friend in your CMIO, your CIO. There are lots of virtual care visions happening. And to be able to consolidate that vision and integrate that vision is going to be part of the ability to scale and really get to the 5-year, 10-year integrated enterprise virtual care solution. So short game, long game, and then you can get to that piece of like, I have this problem that nobody else has solved before, and the ability to, apply that with general technology. So I hope I infuse that with you, Elizabeth, as well. Like your short game isn't a compromise for cutting edge innovation. It is your foundation, but make friends with if you haven't already, other leadership from other disciplines, pharmacy, case management, because that integrated solution is going to be where your foundation takes you in the near future.
Well, thank you both. Really great advice, really great insights. It's obvious you two are very passionate about the topic of really innovating for the next era of care. So thank you both for your time. Thank you to everybody who joined, and have a great rest of your day.